is a pancreatic lesion.
Hey guys.
Okay, so you can see here that we've got this like multicystic lesion affiliated with the pancreas, and the pancreatic duct is a little bit dilated and engorged. And this was a 47-year-old and presented with this lesion here. So we were first a little confused. This actually case went on for like months and months. People thought maybe this was, since they were 47, maybe this was the sequela of pancreatitis, and maybe these were developing pseudocysts. Maybe there was an abscess here. But the really alarming thing to us was that it seemed to have enhancement in it. So these are the venous subtraction images. And in those cystic areas, actually, there was a decent amount of enhancement. And so we said, oh, is this phlegmon, like an abscess that has enhancement in it? But we really couldn't ignore this enhancement. And one of my very smart colleagues, Amir, he actually got what this was. This was a colloid carcinoma, so a mucinous tumor in the setting of basically probably an IPMN. It was a little unusual because the patient's 47 years old, so we were kind of like trying to go down the inflammatory infectious spectrum. So a couple of teaching points about that. So this was what's called a colloid cancer of the pancreas. So this was the case. It's multiple cystic components, but in this case, it's also probably related to an IPMN, and it was enhancing. It tends to be basically extensive mucin with neoplastic cells floating in mucin pools. So even though it looks really, really T2 hyperintense and cystic, it actually will have all this enhancement in it because it has true cells within it. It's frequently associated with IPMNs and much less so with mucinous cystic neoplasm. And one important thing is that it has a much better prognosis than when you get a ductal adenocarcinoma in the setting of an IPMN. So if you have an IPMN, it has all these like really engorged cystic spaces, enhancement. It could be this colloid cancer variant, and that would have a better prognosis.